Join us in sunny San Diego to connect with rheumatology influencers like Rheumcat, at Houseman MD, and at Barack Kumar MD. Catch John Houseman and Joe Rojas daily at 4 p.m., where they will be making room for you, our listeners, to share your convergence experiences on The Daily Roundup, a limited edition podcast episode from ACR Convergence. Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. Congenital heart block is one of the most challenging and heartbreaking complications of rheumatic disease. While it is rare, there has been limited progress in preventing this devastating complication, and once experienced, either as a physician or as a family, it is never forgotten. The manuscript we will discuss today is prospective evaluation of anti-SSA-RO pregnancies supports the utility of high-titer antibodies and fetal home monitoring for the detection of fetal atrioventricular block. It was published in Arthritis and Rheumatology and was presented at the 2023 ACR Convergence meeting. A link to the manuscript and disclosures are in our show notes from today. I'm happy to be joined by the manuscript's first author, Dr. Jill Byron. Dr. Byron is the Sir Derek and Lady Var Morn Professor of Rheumatology and the Director of Rheumatology at the New York University School of Medicine. She directs the NYU Lupus Center and is an internationally recognized physician scientist specializing in translational research and management of systemic lupus erythematosus, lupus nephritis, neonatal lupus, and rheumatic diseases in pregnancy. She has published extensively on neonatal lupus and the pathogenesis of fetal heart block. And it is hard to list all of Dr. Byron's accolades. She's received the ACR Distinguished Clinical Investigator Award, the Evelyn Hess Lifetime Achievement Award, and the Halstead R. Holman Award for Excellence in Clinical Research. She is a fantastic scientist, a wise mentor, and an incredible collaborator, building an environment of scientific synergy in every project she touches. Welcome to the show, Jill.
Well, thank you. I'm not sure I can live up to that expectation. I'm pretty humbled by all your accolades and really excited tonight to speak about a subject that's really near and dear to my heart for the most of my career years. So let's get it rolling.
So the work you present in this study is based on an analysis of prospective data collected through the STOP Block study, which stands for Surveillance to Prevent AV Block Likely to Occur Quickly. Can you share with our listeners the background to that study? How long has it been ongoing? Who is enrolled? What the data and outcomes being collected are?
I just want to make a few comments about heart block in general. Congenital heart block is a very rare disease occurring in about 1 in 15,000 pregnancies. And it's very highly, if not universally, associated with antibodies to Rho. But what is curious about this is that if a mother has anti-Rho antibodies, and this can be true in somebody who has lupus or has Sjogren's syndrome or be totally asymptomatic, the chances of having a child with heart block have been quoted around 1 to 2%, with recurrences slightly higher. So given that, and the fact that the disease can be fatal, and once identified as third-degree block is not reversible. So there's been a lot of discussion in management in terms of balancing the severity and the rarity of the disease against doing monitoring very frequently and the cost of monitoring and maybe even some of the anxiety of the mother in doing the monitoring. So key, I think, to this particular study is to try to evaluate whether the titer of antibody contributes to the risk, not just having the antibody. And as well, a high priority is to try to come up with a way for women to monitor their babies' hearts at home, which would then make them less needy to go wherever or far it might be to get an echocardiogram. And if we could detect disease really early, would that make a difference in terms of reversibility? So the study was designed to ask several of the questions, and today I'll be talking about the first two. But just to say that at the end of this study, we do hope to find out about titer, the utility of the monitoring, which is what we'll talk about today, and whether or not treatment affects. But just a little prelude, we're not going to be talking about treatment today.
So can I take you back to the antibodies though? Because one of the things our listeners really like to know is this regular commercially available antibody testing, or is this something specific you did as a research test? How can they gain access to the antibody testing?
So we're basically to fully acknowledge that the test that we're using was developed in our laboratory. However, it's a test that uses antigens on an ELISA that are available commercially. And the idea here is that many laboratories give you a readout. For example, I'll discuss the Bioplex. If you look at the East Coast in the United States, almost all rheumatologists are getting their anti-Ro antibodies, and they may get them only anti-Ro, or it might be anti-52 or anti-60-Ro. At any rate, the Bioplex only reads 1 to 8 is positive, greater than 8 is high positive, and less than 1. But the problem is, what if your titer was 9 versus 100,000? How would you be able to utilize this assay? And so we developed an assay, and this is also some of our colleagues in Canada did a very similar thing, also published in A&R. Dilution of the blood until you don't see a response anymore tells you how high the titer are. So with the ELISA that we have a range where, let's say, normal people for Ro 52 will be like 100. You could be positive between 100 and 1,000, but then you could be 100,000. So that's why this assay is a little different. But we do plan to work with perhaps a commercial company so that this will become available. I think with this kind of study, we will be encouraging commercial laboratories to give more of a linear response.
Right. It would be super helpful.
Very helpful. Because what I can tell you, as we'll go through this study, if you have low titer, you have a much lower chance. And therefore, you'll see about a third of the patients who are worried probably do not have to worry.
Yeah, don't need to. So I'm actually going to bring you to that straight away. So there's this graphic that you have, a kind of scatter plot. I'm wondering if you can scatter it like fairy dust into our listeners' ears. So it takes you through the distribution of the people who had concordant high titer antibodies, so high titer for both Ro 60 and Ro 52, compared to the concordant low titer antibodies for both, and then those where the titers were discordant. Can you walk us through it?
Well, it would be fun to actually show the graph. So I'm not sure I can sprinkle it out to the audience, but if you close your eyes, what you will see is basically a graph as a dots, right? And each along the x-axis, imagine that you have anti-52 and anti-60. Close your eyes, you're on the x-axis. On the y-axis, you have titer. And let's say that the y-axis goes from 0 to 100,000. Now, in this particular study, I didn't really mention this before, but I think it's critical to explaining at least the fairy dust I'm going to spread. But we made a cutoff in our laboratory of 1,000 ELISA units, above which we thought that would be a risk. Now, how did we come to that number? We came to that number by evaluating women who had a child with heart block and said, gee, in this set of women, and there are exceptions, nobody was less than 1,000. And so because the study, we wanted to identify that the fetal heart monitoring would pick up block. Obviously, we wanted the women who would be doing the fetal heart monitoring to be the most likely to have a child with heart block, right? Because if we had no events in the study, then the study would have been futile. So going back to the fairy dust concept, if you think of all the dots lined up, what you'll see is there were 1/3 of the patients who came in, because a woman could come into this study with a commercial positive anti-Ro. It didn't matter what the titer was. If it was 2, if it was greater than 8. And in other laboratories, it could be, other ones where ARUP, for example, gives you 45 is positive, or it could be 200 is positive. So regardless of whatever the positivity, your blood comes to our lab, and 413, actually there are more than that now, but over 400 patients, blood comes to our lab and we test it. And based on the testing, women are put into 2 groups. Group 1, they have titers for both 52 and 60 less than 1,000. And based on our data, very unlikely to have a child with heart block. Those mothers are monitored with standard of care, because we can't say this is definitive yet, close, but those mothers are monitored by standard of care. The mothers in the greater than 1,000, and there's a line on that graph that shows you that, greater than 1,000 are monitored. And they're monitored with biweekly or weekly echo, standard of care. And as well, they do fetal heart rate monitoring, meaning that they listen to their baby's hearts 3 times a day. Now, on the graph, you'll see that there were 10 cases of block amongst 413 women who are now past 26 weeks of gestation. Why do I emphasize 26 weeks? Because that's the vulnerable period that the fetal heart seems to be susceptible to injury by the transplacental passage of the maternal anterow. So in the graph, you can see every one of the patients that had heart block in this study, all of them actually exceeded for both 52 and 60 the titer that was the 1,000. So in other words, there were no cases in the low group 1, and all the 10 cases were in the second group or the high group. But you'll also notice, if you're staring at this little graph, you'll see that just because you have high titer, that's not the whole answer. So we're improving the risk stratification, but as I think we'll get to at the end, antibody titer alone is not enough. But at least we can say, hey, you don't probably have any risk. Now, for those that have risk, what else is going on? But that's what you're going to see in that graph. And just to bring that point home, even more interestingly, the recurrence rate of heart block is about tenfold your original risk. And the risk there is in terms of the second pregnancy being healthy or not. Say you have a child with heart block. Well, your doctor might say, the patient, I'll wait to have another pregnancy when my titer goes down. That doesn't happen. What we did in the figure after the one I described, we were actually very lucky through our research registry to have blood from 15 mothers during an affected pregnancy and an unaffected pregnancy. And without question, the reason the mother had a second healthy baby after a heart block baby was not because the titers went down.
And so how actually did the pregnancy history factor into which monitoring group they got assigned to?
That's an important point because we had 2 interesting exceptions. Everything in biology has an exception, right? I mean, we live for our exceptions, but sometimes we don't. So it turns out that there were 2 mothers referred to us who actually wound up with low titers. And those mothers were automatically put into the group 2. Now, maybe their biology is different. Maybe in that case, the heart block didn't happen because of anti-Ro antibodies, because they had low levels, I'll be honest with you. In the pregnancy, we put them in group 2 because anyone who's had a prior child with heart block deserves more intense monitoring. Good news is these 2 women did not have a child with heart block in this pregnancy.
So I guess you don't know and will never know, were the antibodies titers higher in the previous pregnancy, or you don't think that's likely?
Oh, no, we know. The answer is no. Absolutely no. That's what's shown in this paper. Absolutely no. So if you look at figure 3, it's very clear that that's not the case.
So there are 2 other really significant findings in the results, and I wanted to give you a chance to cover both of them because I do think this is one of those studies that's going to have really tangible, immediate impact for patients. So firstly, you looked at the fetal heart rate monitoring and how it compared to the surveillance echocardiogram for detecting AV block. What did you find in that part of the study?
So this is really an important part also. So number 1, first of all, can women really identify an abnormality on the Doppler? So let me just describe. This is a little Doppler, like a little handheld device. You put a little gel on your abdomen and you start this monitoring between 17 and 18 weeks, and you do it till 26 weeks. And that's because that's the most vulnerable period when the fetal heart might be injured by the antibodies. So the monitors were intended to do every 8 hours, and not to try to make more than 12 hours between the listening. So the mothers record the baby's heart rate and rhythm through this Doppler. And I should really give you some illustrations of this, but let's just say they monitor that way.
And they're listening themselves, or it's going electronically somewhere?
Yes, so they listen and then they send the audio text to a pediatric cardiologist. The pediatric, in the beginning, We ask the mothers, they get a series of tapes. We have really nice video, and we give examples of where the heart rate might sound different. At any rate, we did have one situation where the mother really had trouble with the Doppler. Very unusual. And because she had trouble, she basically didn't think anything was wrong. So she waited until she let anybody know. And then we wound up saying, well, you just better go get an echo because we're worried. And it's been between more than 2 days. She had a normal echo 5 days before, and she was waiting another 2 days to go to her regular echo. We said, go. And she was in third degree block. And when we reviewed the audio text, it was very clear that there was something wrong. Based on that, which I think is really important, we changed the protocol so that the mother, with our audio texting, and the pediatric cardiologist listens to all the sounds. And you can imagine what an incredible burden that's going to be in real life. So what we're hoping to do at the end of the study is actually to apply AI and try to have the Dopplers actually themselves generate like a green button for it's okay and a blue button for it's not okay. And I think this is really going to happen in the future. But let me just say in the study, so the FHRMs, or fetal heart rate home monitoring, they were done like 3 times a day. Some people might have been a little lax and done 2. And we had some percentage of dropouts who just said it was difficult, but most women did it all. And what was unbelievable is there was no case where an echo was the first identification of block, meaning that doing these FHRMs and doing them, 3 times, 2 times a day, clearly that always picked up an abnormality prior to an echocardiogram. No woman went to her echocardiogram and found out something that was not recognized by the FHRM. So unequivocally, it picks it up. And what's really cool is that normally, this is at least my experience, most of the time when I'm called to evaluate or think about someone who has right now a baby with heart block, they didn't know they had Rho antibodies, they weren't monitored. That is often presentation is third degree. Third degree, if you look at the biology, you look at the pathology, there's no AV node there anymore. So that's a little hard to recover. But when you see second degree, and we really haven't had autopsies of second degree, we hypothesize that it's still in its inflammatory condition. And maybe if we can pick up second degree block, that kind of watershed opportunity, maybe we'll be able to reverse it. We don't know, but obviously, as you know, Vicki, I think the topic that's most important to us as physicians is really prevention of disease. And that's the point here.
And I think this is so important because for many rheumatologists practicing outside of large metropolitan areas, pediatric cardiology isn't always close to where the obstetric services are. And in some regions, there are only limited pediatric cardiologists to serve massive geographic areas. So this is like a huge change in how we can care for these women.
Well, what's interesting here is we have 22 sites across the country, and actually one site in Canada, in Alberta. So across the country, basically we have cardiology sites all throughout the United States. And the caveat was that you had to live within 6 hours of a person who could do an echocardiogram because we didn't want to have more than that as a lag time. And that's been pretty interesting. Almost all the patients that have wanted to be in it, because advertising this word of mouth, we've been able to find a site. And actually, one of our cases where there was a little problem was able to drive and get to her echo and that sort of thing. So I think it's worked out pretty well. I will, say that my partner, Bettina Cuneo, who is a pediatric cardiologist who's also really dedicated her entire career to the study of congenital heart block, she had published on this kind of thing earlier, not so many patients and never with respect to the titer. And it's interesting because, of course, when you do a study again, you realize with this magnitude of patients that there will be some that really are not so comfortable taking on the burden of, I need to make the decision if this is normal or not. And now what's good about this, with the pediatric cardiologist listening, and as we said, hopefully building into the Doppler the knowledge of yes, no, right? Call your doctor, don't bother. There were only 45 abnormal echoes recognized, or at least acknowledged, I should say, by the pediatric cardiologist. So if you think of the thousands of FHRM that were done in this study, 45, only 45, were deemed important to go and get an emergency echo. And of those 45, 10 were abnormal. Now, there are PACs, there were some that were normal, but it's a pretty high percentages that the 45 resulted in something that we identified.
And I would imagine, like, advancing the technology, now that you've shown how effective this was, it actually won't be so hard.
So I think this will be, Dr. Cuneo and I will have this as our next project, no question about it. Because now we have the data to support its importance, and we have it to share with AI so we can actually figure it out. I wish, we had planned this a little better, but I would have had you listen to 2 of the hearts, and you're going to see it's quite fascinating.
Maybe we can get audio clips to put in the show notes. That would be really cool.
Yes, I would be happy to do that.
So let's get back, because the other thing that will massively impact management is this data on antibody titers. So tell us a bit more about the analysis on the antibody titers, and really, what does it mean for rheumatologists looking after these patients in their clinics or advising them on pregnancies?
This is obviously a key message to the paper as well. And basically, this is looking at risk stratification and just giving you some examples. So, for example, of these 413 patients, 152 had titers for 52 and 60 row that were less than 1,000 in the research laboratory. Those patients, not one of them had a child with heart block. These are kind of large numbers now. If we look at 261 patients fell into the high titer. So automatically you're seeing possibly a third of patients that you take care of probably don't need intense echo monitoring. So that's interesting. And now of the 261, we normally talk about heart block. And we say, it's 1%. And there's a lot of controversy, Vicky, about should you monitor? It's a rare disease. It happens so infrequently. That's all comers. But I think what we found, what was interesting, is that we moved that percentage, and I'm just looking at the actual numbers here. We moved the percentage, if you looked at group 2, so to speak, from 0% or, some small amount to 3.8%. So already the data says higher titer means something, because in all textbooks basically says your chance of having a heart block if you have Rho antibodies is 1 to 2%. And that might not sound like a lot, but it's almost double if you think about it. Even though they're low numbers, statistics that still increase, right? So if you look at patients who have a top quartile, that is like, the top 25%, right, of the titer, so they're the highest in that group for anti-Rho 60, you move the incidence up to 7.7%. And if you had a previous child with heart block and you have very high titer 60, that risk, but the numbers are painfully small, I'll admit, it comes out to about 27.3%. And these type of data were also published in A&R with slightly higher numbers by a group from Canada, Yagi and his team. So I think we're pretty clear now that doing titering of antibodies is essential. And we as clinicians have to push these companies to give us titer values so that we're not just saying greater than 8. And I think when we see people with very high Rho titers, and particularly if we can get Rho 60 as well as Rho 52, and someone's had a previous child with heart block, they have a very high risk.
It totally allows you to completely change the stratification of how you assess risk for these women.
There's always a but for everything, right? Nothing is perfect.
There's a but, as there always is.
Oh, God.
And at the end of your manuscript, there's this kind of cliffhanger where you say, but additional factors beyond antibodies are likely. Will you tell us any more?
Well, obviously, I would love to give you the answer, then I would be done. I think what we don't understand, because even in twins, identical, there is not a complete concordance rate, probably only 30%. So that tells you that antibodies are necessary but not sufficient. It tells you that genetics probably play an important role here. And we're really poised to readdress some of the genetics. Nothing was obvious in the more traditional GWA, but we shall see. So there's genetics that may make a difference. And there's been some work from Marie Warren and her group, but we're really not there with the genetics just yet. The other is there may be a different antibody specificity that travels with anti-Rho that simulates in some way that we don't know. And there could be an infection, but also I think it's the in utero environment. There's something about that fetal environment in the setting of genetics and the setting of the right antibody that pulls the trigger. And maybe all fetuses exposed to anti-Ro have some little tickle, but they have the right protective factors. And I sort of think it's the lack of the protective factors.
So more to follow. And I feel like now that you've made this huge step forward, you will hone down, I think, on the patients that are really at risk and other things will come out. Thank you for taking such a deep dive with us on that. I'm going to change tack now a little bit because our listeners really like to hear about the people behind the papers. And so I wondered if you could share with us a bit of your journey in rheumatology. How did you get your start? What drew you to lupus and what drew you particularly to lupus and pregnancy?
I would say that what drew me to lupus, and I'm not kidding you, I was a sub intern at Albert Einstein, and a young woman of African ancestry came in and she said, I got off a plane and I'm really short of breath. And it hurts a lot to take a deep breath. Well, she had a pleural effusion. And she said also her joints kind of bothered her. And believe it or not, I was the sub intern. And that night, I actually found a technician who taught me how to do an LE prep. And I was so excited the next morning when I presented to my attending, this patient has lupus. He said, how do you know? And I said, I did an LE prep. So I think for me, lupus, a disease generally of women, as everybody knows, it's a disease that carries you through your own life. I mean, this is a patient who grows with you. And I've known some of my patients over 30 years, and I'm always excited to see a new young patient. So I like that idea. It expands all of internal medicine. No patient is the same as another patient. No day seeing patients is ever the same. There's nothing routine in the world about lupus, at least not to me. I love teaching about it. I love listening to discoveries about it. And I think it's very exciting to me. And I also understand, in a sense, the trauma people feel. And I will never forget a young 18-year-old girl with very active nephritis who was so upset about how she looked when she took steroids that she refused and she wound up dying. That will never leave me as long as I live. And I think this is just a very unusual disease, and there's nothing more I can say.
So it's a passion. What drew you particularly to studying pregnancy?
Well, I thought pregnancy was interesting. You may know that I started some early career actually on evaluating oral contraceptives and hormone replacement. I think I've always been interested in the kind of estrogen, progesterone. I even studied that in the lab once looking at neutrophils. I think pregnancy, there's man, there's woman, and there's pregnant woman. I think the physiology of pregnancy is interesting. The immunology is interesting. And you have two patients. So I just find the whole sense of taking care of a pregnant woman very challenging and incredibly rewarding.
And you've been incredibly successful. You've consistently had NIH funding, and you've really kind of led the way on several paradigm shifts in the care of patients with lupus, and particularly managing reproductive health in women with lupus. What keeps you going?
I don't know. I think what keeps me going keeps you young, right, to do this. I don't know, there's always, something on the other side. And I'm still reaching for the thing on the other side. And my mother passed away, but I always told her someday I'm going to cure neonatal lupus. And she would say, how are your mouse experiments? And we would kind of laugh about it. I'm not sure that'll ever happen, but we're certainly not there. So I'd like to keep going.
Still more work to do, right?
And I'll tell you something else. We're in an age now. I'm a lot older than you, but now we have single cell transcriptomics. We have spatial transcriptomics. The world is at the feet of the mind that's ready to accept it. I mean, the tools in hand now are just so remarkable. I want to exploit some of them.
I mean, it sounds like you're making huge progress. So you may yet be right. And I look forward to hearing more. So as a scientist and as the head of a department, I know you're often called upon to speak about your research. And sometimes you don't love the public speaking. So do you have any tips for our listeners on overcoming stage fright?
Well, now that's a very interesting question. I'm going to tell you the truth now, I don't know if I want to air this, but I used to pretend I was an actress getting an Oscar or giving an Oscar performance. And therefore, it wasn't really me up there. So I was never worried because whatever it wasn't me. So I think in some ways, it's almost an out-of-body experience. I watch the Oscars every year, by the way.
To get tips.
I'm a movie buff if you ask me about my hobbies, but I think that delivering something to someone in an oration, which is sort of like acting, right? So you just stand up there and you think, they're looking at me. This is amazing. And think of it this way, if you were asked to speak because you were the expert, if you were not the expert, they would never have asked you in the first place, right? So you just have to keep telling yourself that. And I think it works.
It seems to work. You do a great job.
Well, once you get into it, it's really a high and it feels good to do it. But I will admit, I always have to wear green when I give a talk. And one time, why? Because one of my friends said, Jill, you really gave a green dress talk. That was Joan Merrill. And I said, oh, she said, yes, you did. You have a beautiful green dress. This was like years ago. And ever since that time, whenever I give a lecture, something I am wearing is green.
Great. That is a good tip. So I want to ask you also about your role with the Accelerating Medicines Partnership. So this is a collaboration between the NIH, the FDA, pharmaceutical companies, and other nonprofit organizations, really focused on transforming current models for developing diagnostics and treatments. One of their focus areas is autoimmune disease. Can you tell us about the Accelerating Medicines Partnership and your role in it and how you're kind of impacting autoimmune disease research?
So the Accelerated Medicines Partnership started, I think it's about 8 or 9 years ago. And it initially was to deconstruct molecularly and actually through transcriptomics, the lupus nephritis and rheumatoid arthritis. Those were the diseases selected. And basically, we enrolled, because I was on the lupus end, and myself and Michelle Petrie were fairly prominent, along with David Wofsy. And we provided kidney samples to be evaluated in a single cell transcriptomic evaluation. And I think what was really exciting in the beginning was I should say not exciting, but they were concerned, there were doubts, could you really safely get an extrarenal core? And I think we showed that unequivocally getting an extra core for research purposes does not increase the risk of a serious adverse event. And in fact, in 475 biopsies, basically we had 4 that required a transfusion. That's a pretty good record. And I think that knowing that, it really is pretty impressive that we can now look at the kidney with single cell and look at single cells. So in AMP1, we were able to show all the immune cells, many clusters, and we could show the tubules and all the different cells, and had an inkling that high interferon signatures in the kidney, and many cells express high interferon, that these are the patients might be less likely to respond. And I think that paved the way, not necessarily that finding, but just the fact that we could do this, that then paved the way for AMP2. And in AMP2, we're now thinking about spatial transcriptomics. So it's not just knowing about what genes are being expressed by the cell, but like, who's my neighbor? Am I talking to the lymphocyte that's expressing a certain thing versus the macrophage? Is the macrophage talking to a fibroblast and generating scar? So I think this is where it's going. And in AMP2, basically you have different teams. And so we have a disease team called Lockett. That's the lupus team. I love these acronyms. Anyway, lupus, omics, cutaneous kidney, translational group, I guess. So anyway, investigational team. So basically that's myself, Michelle Petrie, Vicki Worth, and Brad Rovin. And we're the lupus team asking some really interesting questions about very early kidney disease and early cutaneous disease. And then we have the RA team run by Jennifer Analik. We have the psoriatic arthritis team run by Chris Richland. And a new partner, in addition to the psoriasis, is Caroline Skibalski. I'm going to mispronounce her name. Anyway, she's running the Sjogren's team. So that's a new disease on the block, and I think that's going to be very exciting.
I really thank you for sharing all of that with us. Looking forward to hearing more. And I feel like you're right. The technology is advancing so quickly that, I'm sure you're going to make progress on all of these areas.
And we have great technical people involved. So it's kind of like you have little stations, right? Someone does spatial, and the different types of spatial. That's the exciting part here. You're really marrying the deeply phenotyped, clinically phenotyped patient with absolute state-of-the-art technology. What could be better?
What could be better? And then actually people who can really take it forward from the therapeutic point of view as well, right?
Well, it's an industry partnership. I'm not sure people are aware. It's an NIH industry partnership. So industry is in there from the beginning. It's a very nice model, I think.
I mean, it has definitely kind of sped up development of a number of agents. So really kind of changing paradigms for how we advance therapeutics in the autoimmune field. So Jill, I want to thank you for being such an excellent guest today, for sharing all of your experience and expertise with our listeners. I always enjoy hearing you speak, even though I know it's not always your happy place. And I thank you so much for taking the time.
It's okay. I like it when I like it. This is a great topic. So thank you. It was a lot of fun.
Well, my thanks also today go to the women who contribute to this field,
Absolutely.
both as patients and as scientists. Science could not advance without women's engagement in research, and the commitment and generosity that these women give to propel this research forward is unparalleled.
There's no question about that. None.
Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRoom on social media, email us at podcast@rheumatology.org, and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.